We then realized that it may not be a good idea and not possible to go to different places and do the programs every time. So we started with the e-learning, starting off with the free YouTube videos. And there are over 400 videos which are available freely in that perspective. And these videos basically are accessible to across the globe. And a lot of people have been accessing these videos over this time. And as we are looking at currently, there are a lot of people who are subscribing even to this program as well. So there are over 1.5 million views which have been given in these videos in terms of this e-learning program. We then realized that we needed to have a structured program rather than just having some videos. So we started off first with a fellowship program from 2017. And till date in the Regency Center of Diabetes Endocrinology and Research, we have had 11 fellows who have been involved. And I remember Dr. Kapoor, when we went for the first time, and he said that, yes, we should start the program. It was one of the few centers which started the program at that point of time. So in the last 7 years, continuously, we have got very good fellows and with good support from the hospital. In 2018, we started the online learning portal MedEClasses, and then a lot of books and application came up. So we have got pediatric endocrine learning tools. We have got fellowship programs in pediatric endocrinology, a 2-year course. And many of the people who are here actually are part of that course. They are coming 4 times in a 2-year period to gain experience, clinical, as well as learning in that perspective. We have developed the MedEClasses endocrinology app, which I was talking about. It's the most downloaded pediatric endocrinology app with over 5,000 installs, a lot of publications coming onto it. We are working in terms of developing connected clinics, which will help out people develop personalized care in terms of specific disorders. So we have developed tools to guide evaluation for growth failure, which have been validated. There are tools for management of diabetic ketoacidosis, which have been shown to reduce the complications of DKA. We have developed a bone age application, which provides within 2 minutes a reliable and valid way to assess bone age, which has already been published. A lot of other interpreters are there, which are being published, include our obesity interpreter, our puberty interpreter, as well as thyroid interpreter. So these interpreters are going to make life very easy. You have to enter the values and you will get the right outcome. And they have been validated in a large number of patients in that perspective. We also developed a DSD interpreter. And the next step, which Vibha was talking about, was the bone age assisted interpretation of growth, in which all the pediatricians have to do is to enter some basic information with regards to the child in terms of their age, in terms of their birth weight and other parameters. And then you have to enter about their pubertal status. And then you can either have a manual entry of bone age, or you can have a data which you have to select the sites and get the right data in terms of bone age. Now, this bone age assisted interpretation of growth is a tool we have been using and validating for the last 1 year in our center. And this has been found to be perfect in terms of not only plotting the data, but also getting a lot of interpretation and whether our puberty and growth is going normal or not. So this is going to be probably a way in which we can really screen a large number of normal children, as well as patients who are coming to different pediatricians in terms of school, as well as clinic, to get the right guidance in terms of evaluation and management from that regards. So we've got different courses. We have on-site course. So we have had 7 on-site courses till now. And yesterday we had a big number of around 48 participants from across the world actually, and over 300 patients who had come from different parts of the country to specifically come and get exposed in this perspective. We have got multiple publications, and we are now coming up today with the 2nd edition of MedEClasses Basic Pediatric Endocrinology.
So we have this 34-year-old male who presented with bilateral gynecomastia, and it was very distressing for him. And he noticed that there was a gradual development of chest since 18 years of age, and he developed secondary sexual characters at the age of 17 years. As compared to his peers, his facial hairs were sparse, and there was no gender dysphoria in him. But he was very much concerned about the non-progression of the phallic length. There was no history of any regression, stalled puberty, mild virilization during puberty, or regression of the gynecomastia. He also had a history of erectile dysfunction. He had no history of any chronic illness or drug intake. In the past history, when we asked him, he told us that he has a bilateral mastectomy previously, but no surgery was done for the genitals. Orally, he had taken no medications, but he has taken 3 or 4 doses of injection testosterone. In the family history, he told us that his elder brother and maternal cousin brothers has similar complaints of gynecomastia and sparse facial and pubic hairs. In the anthropometry, what we found, he has a pretty good height of 180 centimeters, and his upper arm is to lower arm span was ratio was 0.7:1, which means he has a longer legs and arm span of 186 centimeter, which is more than the 5 centimeter of his height. So definitely it's looking like a eukaryotic proportions. On the examination, what we found, he has a bilateral gynecomastia of 6 centimeter in diameter, firm and non-tender. The pubic hair stage was 4, but they were sparse. The testicular volume was 20 ml bilaterally, and the stretched penile length was 4 centimeter. There was no penoscrotal hypospadiasis. So, differential diagnosis, if we made just on the basis of clinical features, so he presented with delayed puberty, along with micropenis, gynecomastia, and erectile dysfunction, with a testicular volume of 20 ml and sparse facial and pubic hairs. So if we consider the micropenis, then differentials could be hypogonadism, XY gonadal dysgenesis, biosynthetic defects, 5-alpha reductase 2 defect, partial androgen insensitivity or minimal androgen sensitivity defect. And if we consider gynecomastia, then we'll have hypogonadism, steroidogenic defect, hypogonadism, hyperprolactinemia could be the cause, drugs, PIS, MIS, and any feminizing tumor. But if we combine all the three, micropenis along with gynecomastia and erectile dysfunction with a testicular volume of 20 ml and sparse facial and pubic hairs, then we get a differential of partial androgen insensitivity syndrome or minimal or the 5-alpha reductase 2 defect. So when we get the investigation done, what we found that his testosterone level was high. It was 938, and his post-SCG testo and DST ratio was less than 10, which was supporting the diagnosis but not diagnostic of the any diagnosis. So we were in dilemma what to do. When we get the karyotype done, it was XY. At that time, he was not ready for the genetic testing. So we reviewed the literature, and what we found, the PIS, that is the partial androgen sensitivity syndrome, has a variable presentation. It could present with penoscrotal hypospadiasis or along with the micropenis also. They could have like familial genitalia and the clitoris hypertrophy only. And during the puberty, the onset of puberty, in some would have 9.6 years, some would have male gender identity, and some could have female gender identity as well. In most of the cases, they develop gynecomastia during puberty. And as the second differential was 5-alpha reductase, so we compared the clinical features of 5-alpha reductase with the PIS, and what we found that the gynecomastia was absent in almost all the cases, and the testosterone to DST ratio was less than 10. And what we say, if the testo-DST ratio is less than 10, it is more suggestive of 5-alpha reductase deficiency. But as we can see in this study, it is not diagnostic for 5-alpha reductase deficiency. Then after a couple of years, he got convinced for the genetic testing. And what we found, he has this defect in the androgen receptor at the seed, 2521 replacement of cysteine with the threonine, and it was hemizygous, X-linked recessive inheritance. So when we go through the literature, what we found that there is a lack of correlation between the genotype and the clinical phenotype of the patients. If there are two family members in the they are suffering from this defect, then one could present with the AIS, that is the complete androgen insensitivity defect, and other could present with the partial androgen insensitivity defect. And the most important and interesting thing is that in the patients with PIS phenotype cases, it is not necessary that you would found the AR mutation in all the cases. The study showed that in only 38% of cases had the AR mutations. Now the question is then why they are having what they have that is causing this clinical presentation of PIS. So they showed that androgen receptor is really essential for viralization, but there are other components of the androgen receptor complex and signaling networks that are required for complete mescalization. These are the non-detected cases of androgen resistance, which might be secondary to the mutations in the 5-UTR region, that is the promoter region, and the other regulatory region. So if we talk about the management, we know that there is a variable presentation of the complete AIS, AIS. So the main thing is gender identity. As in the complete AIS patients, the gender identity is female as they have no androgen exposure during the antenatal period. While in the other, like PIS male and the minimal AIS, the gender of identity is male. We should always delay the genital reconstructive surgery till the puberty or till the patient become major. And according to his or her wish, we will plan the surgery. In the complete AIS, what is recommended that gonadectomy should be done after the puberty, and then we go for the hormone replacement and the urogenital tract surgery. In the PIS female, gonadectomy is done before the puberty, and hormone replacement is done along with the urogenital tract surgery. In the PIS male, that is our patient, if there is an undescended testis, then definitely orchidopexy is done. And if the testis is not working, then orchidectomy should be done. And for the gynecomastia, we should try for tamoxifen. If the patient is not responsive for tamoxifen, then definitely mastectomy is the option. And for the micropenis, we should start with a higher dose of testosterone with the 500 to 1000 milligram 3 weekly. So if I summarize the case and go with the timeline of the patient presentation, he presented in October 2020 with the gynecomastia and micropenis, along with the facial hairs and pubic hairs with a testicular volume of 20 ml. He had a history of mastectomy. Then on an investigation, what we found, he had high testosterone level along with the high LH. He had already received the injection testosterone 250 milligram 3 weekly, but showed no response in terms of increase in the penile length and this decrease in the gynecomastia. So, and when we started the treatment with the higher doses of 500 mg testosterone, then his facial growth improved. They have increased, his penile length increased, and in the October 2020, he was finally convinced for the genetic testing, and it confirmed the diagnosis of PIS, and the semen analysis showed oligospermia. That means he has still the potential of fertility in him, and his erectile dysfunction will be resolved after this testosterone administration. But nowadays, he has stopped the testosterone by him, and still he's facing the problem of gynecomastia, which is not resolved. So the take-home message from this case is that if you have a clinical feature which are strongly suggesting that this is going towards the PIS, and this testosterone DST ratio doesn't support your evidence, and even the genital testing will not show that if all the patients should have this androgen receptor mutation. So if we have this phenotype, we should usually start with a high dose of testosterone, and then we should monitor him further.
He had a large testis. So normally you have gynecomastia with small testis, that is Klinefelter. So large testis with gynecomastia clearly would be going more in favor of a pathological cause like androgen insensitivity. Again, your LH levels were on the higher side and testosterone was also high. So that